I was having settling my patient in ICU, and then I had a lengthy discussion with Prof. Mossad. Okay, fine. Are you guys okay with what we've discussed before on the topic of regarding the cardiovascular punya pathophysiology? Clear ke tak clear? Clear, bagus. Okay, alright, fine. So today we'll discuss a bit about respiratory punya pathophysiology. I have told you guys before, not you guys, the whole, I think some of the group that have the opportunity to have a short case with me. Wait, can you guys hear my voice clearly? Boleh dengar clear tak?
Yes.
Okay, alright. So I've told you guys before, masa exam, for physical examination, we look at the rubric is like this. So the first thing we assess is how is your approach? Did you introduce yourself properly? Did you ask the mother who they are, anak nama siapa? Are you communicating well with them? Do you speak to your patient? Do you speak with the parents? Did you wash your hand or not? I've known one external examiner who always be the chief of examiners, who was even the national head of service for pediatrics. He used to fail students who did not wash their hands, tak buat hand rub. So because if you don't do hand rub, you are not safe. So if you are not safe, however good anything else you do, you are not safe. You don't deserve to be doctors. So how's your approach? That's the first thing we assess. Next is we look at your technique. How you do the assessment. Is your technique good? Your technique of percussion, is it okay? Technique of doing chest expansion, technique of doing all the assessment, is it correct? Or does it look awkward? If you look awkward, it shows that you have not practiced enough. Then probably you need an extra 6 months or so to practice, and so on and so forth. So we look at technique. Next is we look at whether you are able to assess and understand that this is a normal finding. Because understanding normality is very important. And next, the last thing is only then we see how whether you are able to find the abnormal finding. Because if you cannot find abnormal findings, we will guide you. So why don't you auscultate it here? Why don't you do this? We will guide you until you are able to found that abnormal finding. But if it's normal, then you say it's abnormal, then you are creating something, and creating something is not acceptable. It's very dangerous as a doctor. So this is what we assess, and then we'll assess your capability to make diagnosis, differential diagnosis, investigation, and management. So this is what we are going to assess. Okay, all right. So fine. This morning we'll discuss about what we're going to discuss about. So
respiratory examination.
Respiratory examination. Okay. Right. Let me see if I can move things. Yes. Go. Okay. All right. If you remember, last time I told you, what is sound? Sound ni apa? Sound is caused by vibration. Sound is caused by vibration. Okay. What causes loudness of the sound? Loudness is caused by, loudness is affected by apa?
The medium.
Huh? Loudness is affected by amplitude.
Medium.
Loudness is affected by amplitude. So, for example, oh ni saya tak tukar color itu, tak apalah, fine. Okay, so If this is normal, this is normal. This is normal. This is normal. So if the vibration is like this is normal. If the vibration goes like that, so this is higher amplitude. So amplitude affects loudness. Amplitude affects loudness. The more the amplitude, the louder the sound is. Okay. Next is you need to remember there's another thing called frequency. So frequency, yeah, so this is normal, frequency, this is high frequency, and this is lower frequency. So lower frequency affects pitch. Frequency affects pitch. High pitch, high frequency, high pitch. Low frequency, low pitch. Low pitch bunyi dia macam apa? Grumbling sound. Gitu. Kan? Kalau high pitch dia bunyi dia bunyi macam smaller pitch. Pitch and loudness is not the same. Pitch and loudness is not the same. So you need to remember that. Okay. Alright. Fine. That's the first thing. Okay. Now let's go for, okay, what are the physical findings that you can see when you have pneumonia? Okay, let's go. Respiratory examination. Physical findings for a patient with pneumonia. Apa dia?
Reduce chest expansion.
Okay, so first is chest expansion. So first is expansion. Lepas tu apa? Trachea. Expansion, trachea, breath sounds, additional sounds. Lepas tu apa? Lepas tu percussion. Percussion note. Alamak, spelling pun tak betul. Percussion. Lepas tu apa? Vocal. Vocal resonant or vocal parameters. I think that's it. Okay. Alright. So kita bagi. So first, pneumonia. Expansion. What will happen to chest expansion? Affected ke tak?
Reduce chest expansion.
Not really lah. Chest expansion, not really affected.
Not really.
Sama. Kan? Unless kalau it's a lobar pneumonia, it's a big pneumonia. If not, it's not going to be affected. Trachea. What will happen to trachea?
Not affected.
Not really affected unless there is apa? Fibrosis. Ataupun unless there is a collapse. Kalau collapse dia akan pull towards. So dia collapse kan? Dia shrunk. Daripada besar dia shrunk jadi kecil. So dia akan pull trachea towards the lesion. Kalau dia ada collapse. Kan? Okay. How about breath sounds? What will happen to breath sounds?
Increase. Increase the sound.
What are the types of breath sounds that you know?
Vesicular, bronchial.
Sorry.
Vesicular,
So vesicular and
bronchial.
okay. Vesicular or bronchial breath sound. Okay. Normal ke abnormal? Vesicular normal breath sound tak?
Normal.
Normal.
Bronchial breath sound normal ke tak normal?
Normal.
Normal where?
If at the trachea.
So normal at the trachea region, at the midline, at the midline at where your trachea and main bronchus is. So that's a normal finding dekat situ. Kan sebab apa? Kenapa dia vesicular? Kenapa dia ni? Kenapa yang ni vesicular? Yang ni apa bronchial breath sound? What cause the difference? What cause the difference?
The diameter of airway.
Yes, diameter of the airway. So at the midline, the airway is larger caliber. Kan? At more peripheries, the caliber of the lumens are very small. Kan? Very, very small. So they're very, very small. Kan? So the diameter of the airway, I told you before, affected by the amplitude and also the frequency. Kalau macam the frequency is the same, but the amplitude is different. Frequency sama, tapi amplitude dia different. So the how much movement ni dia akan affected. So all this affect the quality of the sound. Lepas tu pula dia tak jadi sama dia punya frekuensi dia. Frekuensi dia kalau the flow dia sama, volume dia sama, tapi daripada besar lepas tu dia kecil. Kan? Lepas tu dia kecil. Kan? Mula macam tu, lepas tu dia akan jadi laju sikit. So the frequency will increase. The flow rate, liters per minute will also increase bila caliber dia jadi smaller. Kan? I always show macam you ada getah pipe kan? You getah pipe tu you buka kat main stopcock asal tu, you buka dekat one flow rate. There's a set volume of water that goes out. And then you kecilkan dia punya lubang dekat depan. So daripada caliber dia besar, kan? Lepas tu suddenly dia kecil. So bila dia kecil, the volume that will total pass through tu sama. Tapi sebab dia kecil, flow rate dia terpaksa naik supaya dia naikkan dia punya volume dia. Faham? So dia terpaksa naikkan. So frekuensi dia akan naik. So bila naik frekuensi, pitch dia akan berbeza. That is why vesicular breath sound is a bit lower pitch as compare dengan bronchial breath sound. Bronchial breath sound ni dia more grumbling type of sound sebab dia lower pitch. Okay. So kalau dekat dalam pneumonia, what will happen to the breath sounds? Breath sound jadi macam mana? What type of breath sound can you hear? Huh? What type of breath sound?
Vesicular?
So normal is okay. So normal breath sound dekat the peripheries are dekat the lung area are vesicular breath sound. Dekat midline is bronchial breath sound. So bila ada pneumonia, you will hear bronchial breath sound. Kenapa kita boleh dengar bronchial breath sound dekat lesion tu? Kenapa? What is the pathophysiology of pneumonia? Apa pathophysiology of pneumonia?
Lung parenchyma infection causing consolidation.
Consolidation. So consolidation. So this is the key word where part of the parenchyma become solidifies. Part of the parenchyma become solidifies. And you remember, you pernah belajar dulu undergrad dulu, undergrad memang undergrad kan? Apa masa basic science dulu apa? You belajar pasal Rinnis and Weber test. Macam mana Rinnis and Weber test tu? Ingat tak? Tak ingat.
Point conduction, conduction tu.
Yes. So you ada apa tuning fork kan? You ketuk tang dan you dengar. Lepas tu tak dengar dah. Lepas tu you letak balik dekat bone. Kat tengah sini. Letak kat tengah sini, you can still hear. You letak dekat bone kat belakang ni, you can still hear. Why? Because again, sound is vibration. And vibration, it's conducted by something. the sound that you can hear, it is vibration in the air, and that vibration is carried into your ear pinna, inside your external auditory meatus. It causes the vibration of your tympanic membrane, that transmits the vibration to your ossicle bones and to the nerve area. Okay, so now you know that already from the Rinish and Weber's test that bone has better conductive capability as compared to air. Bone conduction is better than air conduction. Maknanya vibration that air cannot detect anymore, bone can still detect. Betul? So the point here is solid is a better conductor of vibration as compared to air. Solid is a better transmitter of vibration as compared to air. So sound is transmitted better by solid as compared to air. So if you look at your lung, okay. So if you do this, so if you compare between solid as compared to air as compared to fluid. So solid is the best conductor of, so if you compare to capability of conducting, so fluid is the worst conductor of vibration, conductor of sound, then air, and then solid. So solid is the best conductor of vibration. Solid is the best transmitter of vibration. So if you imagine dekat sini ada consolidation, kat sini ada consolidation, kan? What will happen? Sepatutnya di airway macam ni kan, yang vesicular breath sound. So now you have a solid here. So this solid is a better transmitter of vibration. So bila you oscatate kat sini, you will hear bronchial breath sound. That bronchial breath sound is not generated dekat sini. That bronchial breath sound is generated from the midline, but transmitted transmitted by the solid that is caused by the consolidation. So that is why in pneumonia you can hear bronchial breath sounds. Okay, clear? Faham tak? Faham tak?
Faham. Clear, Doktor.
Okay, how about additional sounds? Additional sounds?
Habitation.
Crepitations, yes. Crepitations or crackles. Crackles, scraps. So they caused by apa? Caused by fluids, movement of secretion, and so on and so forth. So crackles. Okay. How about percussion? Percussion note. Bila you buat percussion, what will happen?
Dull.
Dull on percussion. Kenapa dull?
Consolidation.
Solid.
Okay, if you imagine, this is a surface. This is a surface. This is a surface. This is a surface. Okay. This is a surface. Kalau atas ini air, which is, kalau ni surface ni is our anterior thoracic wall, kan? That is the surface. Atas ini air, bawah ini pun air. Bila you pekas, bila you create vibration dekat sini, you pekas kan, you create vibration. What will happen to the surface? Piece of surface. Atas air, bawah pun air. Bila you create vibration, bila you hit, you introduce energy onto the surface. Sebab bawah air, atas air, dia tak akan ada resistance. Bila tak ada resistance, it will vibrate more. Betul tak? So bila dia vibrate more, dia akan jadi hyper resonant. Sebab apa? Sebab air dengan air tak ada resistance. Bila tak ada resistance dia akan vibrate more. Okay. Sorry, let me answer this. Hello, Assalamualaikum. Yep. Okay. Zul. I'm on leave semuanya ni. Tak perkara aku round tapi not official round. Aku tengah teaching pun, but I'm on leave. Aku tengah cuti ni. Masak. Can you discuss itu masak? Okay, alright. Okay. So, again, piece of paper tak ada resistance, air dengan air, tak ada resistance, dia akan vibrate more. Dia jadi apa? Hyper resonant. Okay. So, now, bila ada pneumonia, you are making a solid particle there. Solid. What will happen bila you introduce energy dekat sini?
More resistant.
More resistant. Kan? Bila more resistant, dia akan reduce dia punya vibration. So, you can see me this piece of paper, you letak solid kat bawah dia. Kalau tak ada air, kalau air, you pekas, dia vibrate a lot. You can see from the video there, it vibrates a lot. Now, you introduce a piece of paper, there will be more resistant. So, this is stony dull. This is dull on percussion. This is dull on percussion. The sound of a surface vibrating on top of a solid. So this is dull on percussion. It still vibrates because it can still vibrate up. There's a flicker of vibration. There's a flicker of vibration. Kan? Tapi it's a bit dull sound dia. Kan? Okay. Now, instead of solid, now you fill down here with fluid. Susah dia ni. You fill down here with fluid. Kan? Semua ada air. So what will happen now? If you remember, fluid ni dia ada counter pressure. Fluid ada counter pressure. It always pushes up sampai dia reach this level, which is 1 atmospheric pressure. So fluid always pushes up. Fluid always pushes up. Okay. Kalau dia ada this surface, bawah dia ada fluid. What will happen is the whole thing, that surface dengan fluid kat bawah tu will act almost like one solid. So dia akan jadi macam, instead of surface and then solid, dia akan jadi macam one set thing. Sebab fluid always pushes up. Dia ada counter pressure. So, sebab itu, what you'll hear is a stony dull on percussion. As compared dengan surface on top of a solid, kan, it just restrict the vibration. That is dull on percussion. Now, bila you have fluid that has counter pressure, it becomes like a one solid. This is stony dull on percussion. Faham? Clear? Kenapa jadi macam tu? Ke tak?
Faham?
Faham? So dull on percussion. Okay. Vocal resonant, vocal fremitus. Apa jadi? With the concept that I told you just now, what will happen to vocal resonant, vocal fremitus?
Increase.
Increase
Kenapa increase?
because of
Because
solid.
solid is better conductor. It's the best conductor.
Yes, because solid is the best conductor of vibration, is the best conductor of sound. So vocal resonant, vocal fremitus akan increase. Clear? Faham tak? So this is pneumonia. Okay. Alright. So now let's go for when we have effusion. Kita ke thorax dulu lah, pneumothorax. What will happen? Expansion apa jadi bila ada pneumothorax?
Reduce.
Expansion reduce. Kenapa reduce?
Lung collapse.
Pneumothorax apa lah? Okay, lung collapse satu, tapi you imagine macam ni. What causes your chest to expand?
Different intrathoracic pressure atau
Apa maknanya tu?
Increase intrathoracic volume.
Yelah, kenapa increase intrathoracic volume? Diaphragm, yes. So diaphragm is the root cause of everything, yeah. So your diaphragm is here. Kawan ni kan? So diaphragm is here. So bila your diaphragm contracts, dia jadi straight macam tu. Muscle kan, dia contract, dia kan muscle macam ni, dia dome. Bila dia contract, dia jadi straight. Bila dia straight, walaupun kita nampak macam tu, tapi it actually causes the chest to expand. Faham? So your diaphragm is the one that causes everything. So bila ada air fill, so your diaphragm ni will not be very effective. So this causes the reduce in chest expansion. Okay, so chest expansion reduce. Trachea, what will happen to trachea? Deviate ke mana?
Collapse.
Kalau collapse, I showed you just now kan. Kalau collapse, dia kalau contoh macam ni kan, bila collapse jadi kecil, so dia akan pull towards. Collapse is pull towards. Tapi bila ada air kan, bila ada air kat sini, dia push semua kat sini, dia push all structures away. So trachea pun akan move away. Collapse, dia mengecut, so dia akan pull towards. Kalau ada pneumothorax, dia pull away. So trachea akan push away from lesion. Okay, faham? Faham tak? Nampak tak ni? Macam balloon lah, you tiup balloon kan. Apa-apa benda sebelah balloon tu dia akan tertolak lah away. Faham tak? Macam tak faham ni.
Faham.
Okay, so push away. So trachea push away. How about breath sounds? What will happen to breath sounds? What will happen to breath sounds?
Reduce.
Reduce. Kenapa reduce?
Sebab air banyak.
Okay, sebab contohnya bila ada pneumothorax kat sini, dia ada pneumothorax kat sini. So this is your lung asalnya kan. This is a very bad drawing lah, I don't really care. So contohnya, so bila ada pneumothorax, it pushes your lung tu, dia akan jadi kecut macam tu kan, sebab diisi dengan air kan. Okay, so what happens is bila areas yang initially filled with lung, sekarang lung tu dah push away kan, lung tu push away. So you know already that air is not a good conductor of vibration. Air is not a good conductor of sound. Kan? And the lung field, tempat jadinya vibration tu, is pushed away. The area yang cause that sound, which is inside the lung field, the airway dalam lung tu, kan, is pushed away. And it is filled by air. And air is not a good conductor of sound. So, breath sound akan reduce. Okay, breath sound akan reduce. Breath sound akan reduce. Additional sounds depends lah. Additional sound depend pada lesion apa ada. Kalau ada pneumonia, sometimes you can hear, but generally it's reduced. Generally it is reduced. You tak ada dengar benda-benda lain banyak. How about percussion note? Percussion note jadi macam mana?
Hyperresonant.
Hyperresonant.
hyperresonant. Sebab apa hyperresonant? Because air underneath the surface, so there's no resistance. Bila there's no resistance, there's minimal resistance, dia akan vibrate more. The anterior thoracic wall akan vibrate more. So dia jadi hyperresonant. Macam mana pula dengan vocal resonance, vocal frequency?
Reduce.
Reduce. Betul. So reduce. Sebab apa reduce? Sebab apa reduce?
Air is a bad conductor.
Sebab air is not a good conductor of vibration. Okay, alright. So now, faham? So now let's look at efficient. Ada fluid, sama ada pleural efficient, sama ada apa nama empyema, benda-benda macam tu. Okay, alright. Expansion. Apa jadi pada expansion? Reduce lah, sama macam air tu. Sebab bila ada fluid kat sini, even if your diaphragm contract, because ada fluid, dia takkan contract really well. Dia still akan, maknanya dia sepatutnya dengan contraction, dia flatten, chest akan move towards out betul-betul. Tapi because ada banyak fluid dekat this area, kan, dia contract pun, the chest won't move that much. So reduce chest expansion. Trachea? Trachea?
Deviated away.
Away. Kenapa trachea deviated away?
Because there is fluid on the
Because-
affected.
Fluid ataupun air, dua-dua pun is a space occupying. It's occupying the space and it pushes all the structures away. Kan? It is a space occupying punya type of lesion. Kan? Bila dia occupy space yang sepatutnya vacuum, that space tu sepatutnya vacuum. Now it is occupied by air ataupun occupied by fluid. So dia akan push everything else away. So trachea pun deviated away. How about breath sounds? Breath sound?
Reduce.
Kenapa reduce? Kenapa reduce?
Because fluid is the worst
Because fluid
conductor.
is the worst conductor of vibration, worst conductor of sound. How about additional sounds?
Also reduce.
Reduce ataupun you can hear some crackles lah, sebab movement of crackles ataupun transmitted sound, sebab well, fluid moves around and you can sometimes hear that movement, kan? Okay, how about percussion note? Percussion note?
Needle.
Stony dull. Sebab apa stony dull? Sebab it's like you are percussing on a stone. Tanpa ada surface dekat atas stone tu. You ambil batu satu, you letak kertas atas. You percuss that paper. So that is the sound of dull. But you buang that piece of paper, you percuss on that stone, that is the stony dullness on percussion. Ataupun you letak satu piece of paper, letak dekat on your lutut, kepala lutut, on your patella. You percuss on that paper, that is stony dull. You buang that piece of paper, you percuss direct on your patella, that is stony dull on percussion. Because fluid has the counter pressure, causing it to act like a single punya structure. That's why you hear stony dull on percussion. How about vocal resonance and vocal frequency?
Reduce.
Reduce. Kenapa reduce?
Worst
conductor.
conductor of
Fluid
vibration.
is the worst conductor of vibration. Fluid is the worst conductor of sound. Okay. Simple. Simple kan? Okay.
Yes, doctor.
Because I've seen student dulu, dia hafal tau, dia buat table macam ni, lepas tu dia hafal. Bila hafal, some of you may get confused. Bila kita poke sikit, you confused. So that is why, if you ask me, I prefer to understand rather than to hafal. Okay, clear? Okay, let's go something else. Okay. let's look at Ronchi versus stridor. What is Ronchi? What is stridor? What is Ronchi? What is stridor?
One type of noisy breathing.
Huh? Apa?
Noisy breathing.
Yelah, okay. So it's a kind of noise that you create lah. What's the difference between Ronchi and stridor?
One
Ronchi is expiratory, stridor is inspiratory
So
sound.
Ronchi mainly is expiratory, stridor is mainly inspiratory. Okay, alright, fine. Lagi?
The pitch.
Pitch, yeah. Ni high pitch. Ini low pitch. Wait. Sorry. Sorry, I need to answer this. Okay, alright. So, tapi okay, what causes Ronchi to be expiratory and high pitch, and stridor to be inspiratory but low pitch? Low pitch ni maknanya bergrumbling, bunyi macam berdengkur tu kan. Sedangkan high pitch ni macam bunyi whistle kan, macam tu. So what causes it to be like that? Kenapa?
The diameter of airway.
Okay, satu diameter of airway lagi. Apa differentiate between, what is the differentiating point between Ronchi dengan, kenapa jadi Ronchi, kenapa jadi stridor?
upper, lower and upper.
Upper and lower airway. Yes, correct. Okay. What is the demarcation point between upper and lower airway? Apa demarcation point dia? Apa demarcation point dia?
Terminatory bronchial.
Ha? Apa?
Trachea, doktor.
Trachea? No. The differentiating for them is actually thoracic inlet. Thoracic inlet. So you differentiate thoracic inlet. So thoracic inlet is the differentiating point between upper and lower airway. Your trachea has upper airway part and lower airway part. This is, they have even slightly different histology pun. You belajar dulu kan, histology of trachea, upper airway dengan lower airway, it's a bit different. So your trachea has upper airway bit and lower airway punya bit. So the differentiating point between upper airway and lower airway is actually the thoracic inlet. Thoracic inlet. Kenapa thoracic inlet ni penting? Apa yang berbeza dia dengan thoracic inlet ni?
The pressure itu.
So actually betul. So generally, how air enters the lung is when negative pressure is created in your thoracic cavity. So bila the chest expands, it created a negative pressure. This negative pressure is the thing that sucks air masuk. The negative pressure, that negative pressure is what creates is what sucks air in. Macam apa benda macam syringe lah, macam syringe kan, you take negative pressure kan, you tarik kan. So that negative pressure is what sucks air into your lung. And inspiration, this is active process. Inspiration is an active process. Maksudnya it's your lung is actively sucking air from environment into your lung. Faham tak? Sebab the negative pressure created. This negative pressure is around your is determined by the thoracic inlet lah. The negative pressure is started from the thoracic inlet. Okay. So this is active process. Expiration active ke passive? Do you push
Passive
air out?
because it recoil.
It's a passive recoil. So expiration is a passive recoil. It's a passive recoil. So bila the passive recoil, it's just that your lung is now going back to the normal size and slowly they push air outside. They push air from inside your lung to out. Inspiration is an active, you sedut, and then you relax, you slow keluarkan air. So that is expiration. Okay, now let's see what happens in upper airway obstruction. What happens in upper airway obstruction? Kenapa upper airway dia masa inspiration bukan masa expiration? Okay, for example, so again back to the physics that I've been telling you. Sound is caused by vibration. Sound is caused by vibration, and that vibration is caused by turbulent flow of air, fluidity of air. The air movement causes turbulent flow. Kan? That turbulent flow is what we can hear and what we can appreciate as sound. Turbulent flow vibrates, vibration causes sound. Okay, alright. So if you imagine, inspiration is an active process. Negative pressure inside your thoracic cavity is created by expansion of your chest. Chest expansion causes negative pressure in your lung, in your thoracic cavity, and this negative pressure is the one that sucks air from environment into your lung. Okay, so if you imagine we create a, so and if you can see the caliber of lumen kan, dia daripada besar, atas ni mulut kita, hidung kita kan besar, kita punya sinus cavity semua besar. Lepas tu daripada besar tu dia makin kecil, trachea pun makin kecil sampai kat main bronchus pun makin kecil. So it's gradually decreasing in size. Makin bawah, makin jauh, makin kecil. Makin atas, makin besar. Kan? Okay, so if we create a obstruction here, ada obstruction kat sini, atau obstruction dekat sini ke apa ke? Itu tak best, kita tukar balik. Okay, if we create obstruction dekat sini, dekat your tekak, for example, obstruction kat situ, what happens to the flow of air? So daripada besar, tiba-tiba ada obstruction. Dahlah dia makin kecil kan? Dahlah dia makin kecil dan dia panjang, ada obstruction. This obstruction will cause turbulent flow. Faham tak? So this turbulent flow is what causes the sound. Lepas tu dia panjang, dia jauh, and the caliber is still big. So this is what causes the sound. Yang masa inspiration, because it's a forceful sucking of air. It's a forceful sucking of air because of the negative pressure, so causes lots of turbulent flow. Dan dia panjang, panjang daripada atas sampai ke bawah. So that is why you can hear inspiratory stridor. Caliber is still big. So bila caliber dia big, the pitch, the frequency is low. Bila the caliber is big, the frequency is low. Macam saya cerita tadi kan, besar, dia makin kecil, kan? So kalau volume dia sama, bila kat kecil ni dia akan volume dia, frekuensi dia laju sikit sebab dia nak pass through same volume, for example. Okay, nampak? So what happens masa expiratory? kenapa masa expiratory kita tak dengar expiratory stridor? Why? Sebab kalau you tengok expiratory is a passive recoil. So bila passive recoil, tak ada pressure yang push air to out. It's not a forceful, tak ada forceful. Dia macam ikut suka dia lah berapa slow dia nak pass. So, and then the caliber pula daripada kecil, dia makin besar. Kecil ke besar. So maknanya dia daripada kecil ni, walaupun jumpa obstruction ni pun, it is still bigger than what they have lower here. Faham tak? So bila the caliber makin besar, turbulence flow created tu tak banyak. And because the obstruction tu dah dekat hujung-hujung, turbulence flow created ni pun it's not that significant, and it opens to a bigger punya caliber. It opens to the environment. So bila you auscultate, you tak dengar banyak sound. That's why you don't hear expiratory punya stridor. Unless the obstruction is very, very severe. Kenapa? Bila obstruction is very severe, acute epiglottitis for example, ataupun foreign body expiration, now you can hear biphasic stridor. Kenapa you hear biphasic stridor? Because the obstruction is severe. Sampai even expiration must be active process. So now untuk keluarkan air, your lung has to push air out. Bila dia jadi active process, bila ada pressure, bila ada extra energy, now more turbulence flow created. Bila more turbulence flow created, baru you can hear expiratory stridor. So now it becomes biphasic stridor. Kalau obstruction is severe. Okay, faham tak? Faham ke tak faham?
Faham.
Okay, alright. So now let's look at when the obstruction is at the lower airways. Obstruction is at the lower airways. Dekat sini macam asma kan? Dekat sini kan? So, masa inspiration ada bunyi tak?
Tak ada.
Tak ada.
Kenapa tak ada?
Tak ada apa-apa resistance nak masuk.
Sebab satunya bila masa inspiration, again I told you, dia create negative pressure dalam intrathoracic cavity ni kan. Dia create negative pressure. Your pleural space ni dia pull everything out, dia tarik keluar. So whatever, kalau benda yang mula dia macam ni kan, bila dia kena pull dia akan membesar sikit. Alveolar pun besar sikit sebab nak pull air in. Kan semua benda membesar sikit. So bila semua benda membesar sikit, even ada obstruction pun it reduces a bit. Reduces a bit sikit je. Tapi it still significant lah kalau dia kecil dia berapa milimeter je. Kan? And then apa lagi? And then sebab dia dah dekat ujung dah. Dia dah dekat ujung. Daripada sini ke sini sikit je, berapa milimeter je. So turbulence flow ni created tapi tak banyak sangat. So that is why you don't get much inspiratory ronchi. Kenapa ronchi? Sebab dia smaller caliber kan? Smaller caliber kan, besar, volume lebih kurang sama, tapi dia daripada besar dan dia kena lagi laju. So it causes the high pitch, high frequency, high pitch, and you get ronchi. It's the same thing. Ronchi stridor ni sama je. The only difference is the frequency, the pitch. Okay. So masa inspiratory, sebab dia dekat ujung, so you don't get much inspiratory punya sound. Okay. How about masa expiratory? How about masa expiratory? So masa expiratory, walaupun it is a passive recoil, tapi the caliber of the lumen ni is very small and jauh ni daripada hujung sini nak sampai atas ni jauh. So walaupun dia passive recoil, tapi dia punya rate of expulsion of air. Expulsion of air tu reduce sebab ada obstruction. So air daripada sini bergerak ke sini tu slow lah sikit. Bila dia slow sikit, dia akan affect your FEV1 over FVC. Sebab dia akan slow sikit. Dia akan slow sikit. keluarkan air, expulsion of air tu slow sikit walaupun passive recoil. Sebab ada obstruction and dia panjang jauh dari sini sampai ke situ. That is why you can hear expiratory bronchi. Faham? Expiratory bronchi. Tapi kalau obstruction dia panjang, contohnya macam foreign body expiration. Contohnya macam severe asthma kan. Banyak semua dah obstructed. Apa jadi? You akan dapat biphasic bronchi. Biphasic bronchi. Bila dia severe obstruction. Okay. Faham? Clear tak?
Clear.
Okay. Yalah, cukup lah. That's it.
Doktor,
Ah,
yang low pitch, high pitch tu sebab frekuensi je lah.
frequency, yes. Pitch is determined by frequency. Pitch is determined by frequency. Loudness is determined by amplitude.
Understood, Doktor. Thank you.
Understood? Clear? Okay. Why I always teach this to students because okay, some people they are very good at memorizing things. Some people are very good. Dia senang hafal dia. I'm not like that. My memory is very bad. But that's why how I study is I try to understand things. So I think sama juga. So I'm trying to get you guys rather than hafal, rather than memorizing things, why don't you understand things? Because when you understand things, walaupun you akan lambat sikit jawab, but you will not get confused. You will not get confused. So how I explain this, yang minggu hari tu kita discuss pasal cardiovascular, and today we discuss about respiratory ni, is very basic way of explaining things. It's a very basic way of, it's a very simplified way of explaining things. I'm not going into the details. I'm not going into all the facts and things, but that's a basic, simple how to understand the physics behind all the physical findings. Okay, clear? Any question? I actually thought nak discuss pasal renal tapi I tak lagak lah. Tak apalah, next time sebelum your professional exam kot. We'll discuss back about ni ataupun lain kali ke. Okay, alright, cukup lah
Doktor,
Yeah.
I have question regarding yang table tadi tu yang kita tengok tu. Kan tak ada AN3 kan. So AN3 will always follow breath sound kalau reduce akan, so AN3 akan reduce kan macam mana Doktor?
Yes, yep. Breath sound reduce, AN3 reduce lah. AN3 is just, AN3 is breath sound lah. AN3 is breath sound. If breath sounds increase, then AN3 is increased. Because you are hearing breath. When you auscultate, when you look for AN3, it's actually you are hearing breath. I just summarize, I just sum up both AN3 and breath sound. Because it's easier for my brain to process.
Alright, thank you Doktor.
Okay, alright, sekolah. I think that.
Doctor, for bronchiolitis,
Okay, alright, nice. Okay, habiskan soalan dulu.
nak go through je macam the other ones. Boleh ke?
Okay, what is bronchiolitis?
Inflammation at the bronchiole.
Inflammation of the itis of the bronchiole. Bronchiolitis is itis of the bronchiole, so bronchiolitis. So, what's the pathophysiology of bronchiolitis? So, inflammation, causes apa? If you have this airway, bronchioles, inflammation, ni dia punya wall kan?
Exudation.
Dua, okay, satu exudation. Exudation. Bila exudate dia banyak secretion. So increase secretion. Nombor dua, inflammation causes apa? Thickening. Thickening of the wall. Wall thickening. Kan? Wall thickening. So thickening of the wall ni akan reduce the reduce the thickening of the wall. Thickening of the wall akan reduce the
Diameter.
caliber lah. Caliber. Thickening of the wall. Kan? And plus minus so ni thickening of the wall lah. Thicken wall. So plus minus dengan bronchospasm. Plus minus bronchospasm. So these are the three pathophysiology of inflammation in the bronchioles. Satu, increased secretion. Nombor dua, thicken wall. And nombor tiga is bronchospasm. Okay. If you look at asthma. Apa pathophysiology dia? Okay, you need to know pathophysiology of asthma. Pathophysiology of asthma is a favorite question of mine in exam. So if you get me for asthma, I will ask you about pathophysiology of asthma. So pathophysiology of asthma ni panjang, I'm not going to go there, but mainly is bronchospasm lah. The main pathophysiology of asthma is bronchospasm. Then you need to know lah about the role of leukotriene, the role of IgE, the role of mast cell, the what type of hypersensitivity and so on and so forth. So you need to know that. So for asthma, remodeling, lung remodeling, semua you nak kena tahu pathophysiology of asthma. But the main is bronchospasm. That is why the treatment for asthma is apa? Beta agonist.
Bronchodilator.
Itulah bronchodilator beta agonist macam salbutamol apa semua kan. Then you need to know lah what is salbutamol ni group apa, beta agonist kan. And then you have the benda macam ipratropium bromide. Ni apa ni? Mana apa yang mast cell stabilizer, apa yang leukotriene inhibitor and so on and so forth. Okay, so asthma is bronchospasm. Dua-dua causes obstructive airway disease. Where there's obstruction in your airway lah, kan? Okay. Tapi as compared di antara asma dengan bronchiolitis ni, asma pathophysiology mainly is bronchospasm. Bronchiolitis, the pathophysiology, bronchospasm ni maybe ada, maybe not. That is not the main pathophysiology. The main pathophysiology is increased secretion and thicken wall because of inflammation. Okay, faham? So that is why the physical finding in asthma is ronchi. The main physical finding of bronchiolitis, well, boleh ada ronchi sebab dia ada airway obstruction, tapi dia ada cracks. Dia akan dapat fine cracks. That is the main physical findings in bronchiolitis. Okay, nombor satu. Nombor dua, treatment pun berbeza. Sebab in asthma, the main pathophysiology is bronchospasm. So the treatment will be something that relaxes the smooth muscle, which is bronchodilator. Bronchodilator causes relaxation of the smooth muscle and reduce the spasm. Tapi bronchiolitis, the mainstay of treatment is something to reduce the secretion and reduce the thicken wall. Kan? Bronchodilator is not the mainstay of treatment untuk bronchiolitis. Okay. Faham? Itulah, sebut je. Okay, sekolah. I'm exhausted
Okay,
already.
doktor. Doktor, boleh ke tak not before exam pun tak apa, after exam ada kelas nefro.
Ya, exam bila? Selasa.
Habis Jumaat depan. I mean, we can also ajak terus budak yang posting pitch lepas tu.
Ya. Boleh juga.
Sebab boleh doktor, boleh ke?
Sekejap bila I'm very busy I need to see.
It's okay doktor, within 2 months forward.
Boleh lah, boleh. Macam ni, why don't you get back to me on should we say Monday morning tak? You get to me Monday morning. And then we'll see.
Okay.
Yeah? Okay? Monday you tak ada apa-apa kan? Exam hari Selasa. Kan? So get back to me on Monday morning. Okay, alright.
Okay, Doctor.
Okay, that's it. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Doctor.
Thank you, Doctor.
Salam. Thank you,
Thank you,
Doctor.
Doctor. Thank you so much, Doctor.